Hi, I'm going to talk to you about a operation that I believe you have some interest in, and I want to give you a thorough understanding of this condition because it isn't often told. The story of PRK isn't often told, and I want to make sure that you know what I think about it and why I think those thoughts. I have a handout that I'd be happy to give to you if you are interested, okay? And what we're talking about here is part of the informed consent process, so that when we talk about the risks and the benefits and the alternatives to PRK, which is the operation I'm recommending to you, this will be a part of that. So I first started performing PRK in 1995 when it first became available. I then started doing LASIK in 1997, and I performed it for about 6 years. PRK was the original treatment. LASIK was supposed to be better, but I can tell you from having done it, it's not better, and it's actually less good for your eye than PRK is. I no longer recommend LASIK to any of my patients. I am a very careful surgeon. I cut no corners. I do everything that is considered to be advantageous for the patients, even if it takes more time, and I have to occasionally tell some surgical candidates that they're not good for the operation. In PRK, the new shape of the cornea is accomplished after the surface of the cornea is removed with a blunt instrument after the eye is fully anesthetized. This is like a fancy scratch on the cornea that I produce. The laser is then focused on the surface of the cornea. The excimer laser, as it's called, then removes a certain amount of the cornea in a specific shape on the surface of the cornea to create the new corneal curvature. This makes the glasses prescription very small, so you can see well without your glasses or contact lenses. And remember, in PRK, there is no flap at all. In LASIK, the operation begins by cutting a thin sliver of the cornea with either a metal blade or a laser. Then the surgeon lifts the flap up and out of the way like a toilet seat cover so that the flap is still connected by a hinge. Once you lift up the flap, the excimer laser is then focused onto the bed, which is the name for the part of the cornea that is still facing upwards. The excimer laser then removes a specific amount and shape of the cornea, just like PRK does, only with LASIK it's done from the bed to create the new corneal curvature. Then the flap is laid back down upon the bed. The new shape that is created in the bed is now supposed to be transferred through the flap to the surface of the flap where the actual focus of light takes place. With LASIK, the new shape is under the cover of the flap. In PRK, the shape is made directly on the surface where the focus actually takes place. During the 6-year period that I performed LASIK, I witnessed almost every complication that has been described. All of the complications in LASIK are attributed to and associated with the flap. The corneal flap does not heal in 1 day, 1 week, 1 month, or ever. It never heals. The cornea and cartilage are the only two tissues in the body that do not have a blood supply. All traditional healing in your body takes place from what's called fibrovascular healing. All traditional takes place this way and requires a blood supply, so that if by chance cartilage acquires a blood supply, it actually turns into bone. It has to not have a blood supply to remain cartilage. The cornea cannot have a blood supply either because you can't see through blood. And so you've got to make sure that the cornea remains free of blood vessels. The primary way that the flap reattaches to the bed is through a suction force that is created by a pump that's located on the inner surface of the cornea. This layer is known as the endothelium. The endothelium pumps water out of the cornea into the eye and this pump creates enough flow of water to produce a weak suction. This is the only thing that holds the flap against the bed for the first day. As the small horseshoe-shaped cut of the corneal surface, which is called the epithelium, heals over the first day or so in LASIK, the part that's around that flap that you lift up, this healing of the epithelium in that little curvilinear line adds a small amount of additional strength to the bond between the flap and the bed, but not much. The long-term adhesion of the corneal flap to the bed is accomplished by the deposit of tissue glue, also known as ground substance or glycosaminoglycans. And that is made by just a few of the cells that are normally in the cornea called keratocytes. This glue that is deposited is a very weak way of adhering the back of the corneal flap to the surface of the corneal bed, which is the part of the cornea that the laser was initially focused on. The proof that this attachment is weak is demonstrated by being able to lift the flap up years later without having to cut it again. It's also well described that the flap can be damaged from an airbag that might hit from a car accident that might hit you in the cornea years after LASIK, and that impact from the airbag can either damage the flap or tear it completely off of your eye where it's lost. When the surgeon puts the flap back in place after the excimer laser reshapes the bed, the back of the flap has a different shape from the bed, since the laser only removes cornea from the bed and does not remove anything from the back of the flap. This means that it is impossible for the two pieces to ever fit again properly forever. The only way the flap and the bed would fit together properly is if you just cut the flap, lifted it up, and put it back again without doing any laser treatment at all, in which case you wouldn't be doing LASIK surgery. In LASIK, when the now mismatched shape of the back of the flap and the bed are put back together, it can create folds in the flap. These folds can be small when they're called microstria and likely degrade the optics of the cornea a little. Microstria are always seen by the surgeon during the exam, but the patient often sees well. In truth, the patient would likely see better without microstria, but there's no longer any way to know. You can't have it both ways. Microstria are usually left alone, and often the patient is not made aware of them since they are seeing okay. If the folds in the flap are big, then they're called macrostria, and these can create meaningful visual disturbances. Think of the flap like a sheet on a bed. If the sheet has little folds, then the shape of the underlying bed is visible on the surface of the sheet. If the sheet, in this analogy the flap, has big folds, then the underlying shape of the bed is not transmitted accurately to the surface of the sheet. If a patient develops macrostria, they will likely have to go back to the operating room to have their flap lifted, not recut, and then have it floated back into place. This might require the surgeon to stretch the flap, since once the folds form, they sometimes become fixed and they cannot be made reliably flat ever again. In LASIK, once you cut the flap and lift it off of the bed, anything that's in the room can end up trapped in the bed. Microscopic bits of stuff can get into the bed that are literally impossible to remove. This can be residual makeup, debris from the eyelashes, like a common condition called blepharitis, or even dust in the air. Even if the surgeon sees the debris at the time of the operation, it is sometimes impossible to remove. Even when vigorous irrigation or scraping are performed, since the debris gets wedged into the fine structures of the cut cornea on the back of the flap and the surface of the bed. This retained debris can be optically important and change the visual outcome or it can cause infection or inflammation, which requires additional treatment and can lead to permanent reductions of vision. None of this can happen with PRK. There is no flap. The surface of the cornea is known as the epithelium. This is the part of the cornea that is removed from the surface in PRK just before the excimer laser is used. In LASIK, the epithelium is not removed, but is cut when the flap is made. It is a horseshoe-shaped cut like the perimeter of a toilet seat cover. Sometimes, after LASIK, the epithelium can get into the space between the corneal bed and the back of the flap. This is called epithelial ingrowth. And when this happens, it can create a lot of flap distortion and wrinkling, which can severely degrade the quality of your vision. The epithelium is opaque too, so it can decrease the vision this way as well if it is near the middle of the cornea. Sometimes the epithelial ingrowth is minor and no treatment is recommended. The patient may not even be aware that they have this because they might be seeing okay. They may see they may see better if they did not have epithelial ingrowth, but again, there's no way to know this because you can't have it both ways. If the epithelial ingrowth produces a meaningful reduction in vision, then the surgeon needs to take you back to the operating room. And in the operating room, the flap will again be lifted. You don't need to cut it. But since the epithelium creates a stronger bond between the flap and the bed, it is easier to damage the flap when lifting it where there is actual epithelial ingrowth. Once the flap is lifted, the surgeon will scrape the internal surfaces that have attached epithelium on them, and once all the visible epithelium is removed, the flap is put back down onto the bed. This reoperation can change the shape of the flap and the bed. The shape change will affect the focus of the cornea because that's exactly how LASIK and PRK work, by changing the shape of your cornea. Epithelial ingrowth can occur more than once, and if this occurs, sometimes the flap is actually sewn back into place with sutures. Epithelial ingrowth will always delay the achievement of a stable final visual result, and it often degrades the final visual outcome forever. This cannot occur in PRK. There is no flap. In LASIK, when you make the flap, you cut across the corneal nerves. Corneal nerves are necessary for the cornea to sense the environment and to keep your eyes properly moist. If you damage the corneal nerves, they do not send a trigger back to the brain that tells the brain to release tears. Everyone who has PRK and LASIK will develop a drier eye for around 3 to 4 months after the treatment because the excimer laser removes cornea in both operations to about the same degree. This is why I do not recommend either of these operations to patients who have a clinically dry eye, unless we first boost the tear production with special medications and then prove that the dry eye has been normalized before having these kinds of operations. Even though PRK does injure the corneal nerves some, it injures them less than LASIK because you are treating from the top down. In LASIK, you are severing the corneal nerves first when you create the flap, and then you are irradiating the bed with the excimer laser. This produces two different injuries to the cornea. LASIK is associated with a higher risk of dry eye and a longer period of time of recovery from dry eye as compared to PRK. With both PRK and LASIK, the excimer laser removes cornea as it makes the new desirable shape. When you take away too much cornea, or you start with a cornea that is too thin or too weak, the laser treatment can cause the cornea to lose strength. A weakened cornea can then bulge forward like a balloon that is blown up with a weak wall, can kind of pooch out. And this is called corneal ectasia, where the cornea pooches out. If you develop corneal ectasia, you cannot fix it with the excimer laser. The excimer laser just removes more cornea, and that would literally make the problem worse. The only way to treat this is to wear a rigid gas permeable contact lens for the rest of your life, or to have a full thickness corneal transplant. To wear a rigid gas permeable contact lens safely, you also have to make enough tears. People who have LASIK have more reductions in their tear production compared to patients who have PRK. I have never seen a case of corneal ectasia in a PRK patient, but I have seen it in LASIK patients. Corneal ectasia can happen with PRK, but it is really rare because you haven't destabilized the cornea with the initial flap creation. The corneal thickness is measured in all PRK candidates, and the amount of treatment is also considered. The treatment of a stronger glasses prescription removes more cornea. Plus, if patients have a large pupil and need a larger treatment size, this also removes more cornea. If the combination of a thin cornea, a large prescription, and a large pupil require the removal of too much cornea, I will advise against you having PRK. If the combination of these factors makes the amount of cornea removed excessive, and this will increase your risk of corneal ectasia, I will let you know. Then you can decide what you want to do. With LASIK, the amount of corneal treatment includes the thickness of the flap. So PRK gives you more room to remove cornea when you have a thin starting cornea, or a relatively large prescription, or a large pupil. You might say, why do people have LASIK then? It's a good question. With LASIK, because you do not directly treat the surface of the cornea, you will have a slightly more rapid gain in your vision. Most people who have uncomplicated LASIK see very well the day after surgery. With PRK, because you treat the surface, you will not have the vision that LASIK patients have for about 4 days. This is because a bandaged contact lens will cover the surface of your cornea while it heals. And for most people, they will have around 20/40 vision until the surface is restored. Then, once the epithelium grows back, most people with PRK see about the same as LASIK patients do on the first postoperative day. Because in LASIK the surface is not treated, most patients have very little postoperative discomfort. With PRK, some patients have some discomfort that is described usually as a feeling like you went swimming in a chlorinated pool all day. It burns some, and your eyes might water, and they might be somewhat light sensitive. This discomfort is much less in patients who normally wear contact lenses, because chronic contact lens wear causes the cornea to actually become relatively numb. This discomfort is moderated by the bandaged contact lens that we put on your eye after PRK, anti-inflammatory eye drops which we can provide to you, regular pain medicines like Tylenol, Advil, or Aleve, and sometimes an ice pack. After the surface grows back under the bandaged contact lens, the eye again feels like a LASIK patient on the first postoperative day. It feels like nothing. So the only benefit to LASIK is 3 to 4 days of relatively better vision. Remember, PRK patients can usually drive the day after surgery, so the vision isn't at all poor, and the avoidance of moderate treatment discomfort for about 3 to 4 days. The clear benefit is not having a flap, and a 100% guarantee that none of the flap complications and the permanent visual losses associated with them can possibly occur. To me, the choice is easy. I am happy to tell people the truth about LASIK. The industry has been dishonest about LASIK. The FDA actually had a fact-finding mission regarding this very topic. The shortcomings of LASIK are not generally told to patients. This is because patients often come to the eye surgeon asking for something that they are pretty sure that they want. The marketing for LASIK has been very effective, and the time it takes for the surgeon to teach the patients about the safer alternative PRK is often just not taken. LASIK can be an easier path for them to take, and if you tell the patients about the risks and they accept them, then the surgeon can fall back on the fact that at least the patients knew that these risks were available in patients who have LASIK. I have not done LASIK since I learned about all of these things firsthand as the surgeon. Remember, I'm as careful an eye surgeon as you will find. I take no unnecessary chances and cut no corners. If after hearing about these differences and having a chance to ask me all of your questions you prefer LASIK over PRK, I would be happy to refer you to someone who can correctly perform LASIK for you. I believe the very small advantages of LASIK are far outweighed by its disadvantages. Now I'm going to talk to you about PRK, the evaluation, and the pre- and post-operative PRK considerations. When you have your preoperative measurements, we will measure how much tears you make. Dry-eyed patients are not good candidates. If you do have clinically dry eyes, we will discuss the option of treating you with a drug like Restasis or Cequa or Xiidra, which can help you make more of your own tears and help you normalize your tear production. Any patients that have conditions that are considered autoimmune are not good candidates. Patients who have PRK or LASIK that have an autoimmune condition are at an increased risk for a serious complication called corneal melt, which can result in total blindness. Patients with lupus, myasthenia gravis, Graves' disease, rheumatoid arthritis, mixed connective tissue disorder are examples of some of the autoimmune diseases that people should not have these treatments for. We have to prove that your glasses prescription is in a certain range. If the prescription is too strong, then you have to take away too much cornea and you're not a good candidate. We have to prove that your glasses prescription is stable and unchanged for at least a year. This is especially important for young patients less than 25 years old who often have a change in their glasses prescription as they get older. We will measure your pupil size in near total darkness to approximate your pupil size at night when you might be driving. The traditional treatment size for the laser is 6.5 millimeters. The entire cornea is about 11 millimeters, so you only treat the center of the cornea with LASIK and PRK. If the pupil size in darkness is larger than the treatment zone, you might have an increased risk of halo, glares, and rays around lights. This is because some of the light will go through the part of the cornea that was treated with the laser, and some will go around the treatment zone. If you have a big pupil, it means you have an increased risk for these nighttime disturbances. Some drops, like ones used in glaucoma, can be used at nighttime to make the pupil smaller, and this can be an effective treatment if you have these nighttime changes after PRK. If you have a big pupil and a large glasses prescription, you may not be a good candidate to treat. As you expand the treatment size of the cornea, that takes away more cornea in the center, and this increases your risk of corneal ectasia. I might have to tell you no. Your corneal thickness will also be measured. PRK works by removing the cornea, and if you start with a cornea that's too thin, there might not be enough to treat your glasses prescription, especially if it's a big prescription, or if your pupil is large, which may require a larger treatment zone, which also removes more cornea. We will also make sure that you do not already have a cataract. Performing PRK in patients with cataracts is totally safe, but as the cataracts progress, they will always change your glasses prescription. This will progressively change the excellent results that you will achieve after your PRK. If you are willing to have PRK and have it only effectively last 5 years or less, then we can agree to do your PRK if you have a cataract. Most people who pay for PRK want it to last longer than that. I often recommend that patients with cataracts save the money that they were planning to spend on their PRK and save it for the premium intraocular lenses or implants that are used during cataract surgery. These lenses, unlike PRK, give improved vision at the distance and near, which PRK and LASIK do not do. With PRK and LASIK, you only get one distance. PRK only produces change in the focus of each eye, and only for one distance. This means that you will need to wear reading glasses for near vision after around the age of 40. This is even true for patients that are naturally nearsighted who can currently comfortably see up close without glasses. In these patients, they are trading their natural nearsightedness for excellent distance vision. The only patients that are 40 years and younger who have PRK and LASIK can obtain excellent uncorrected vision for the distance and for near, but when they enter their 40s, they're going to lose their ability to see up close as they would if they didn't have the laser treatments. Sometimes we will treat patients so that their dominant eye can see well in the distance without glasses, and their non-dominant eye can see up close well. This is called monovision. And we can let you try this experience with a short trial of monovision contact lenses. This will let you see what it looks like in your everyday life. Monovision always will make your depth perception bad. So I always recommend driving glasses to bring the eyes together and restore proper depth perception for this common dangerous activity, which is driving. PRK and LASIK are not covered by medical insurance plans, but they might be covered by some vision insurance plans like VSP, iMed, Block, and Spectera. These insurance companies provide a discount on PRK, but they do not pay for it completely. PRK is a real operation, and some people get nervous. For this reason, after we have you explain everything and your questions have been answered and you have signed the informed consent document and any other documents that you need to, you will be offered a pill about an hour before your surgery at the surgery center to make you feel more relaxed, similar to Valium. You don't have to take this pill if you don't want to, but for many people, they find that to be desirable. You will be given prescriptions for several eye drops that you will be using after your surgery. No drops need to be used by you before surgery unless you are using artificial tears or the dry eye medicines we spoke of earlier. In that case, you would want to use them normally as you would before your surgery. The prescription medicines that I'm going to ask you to obtain can be obtained by you at the pharmacy before the day of surgery. The costs of these medications is not included in the cost of the surgery. After surgery, it is suggested that you take whatever you normally take for pain, even though you won't have any pain, but to prevent it. This includes drugs like Tylenol, ibuprofen, aspirin, Aleve, Advil, and I would recommend that you take one of these drugs every 4 to 6 hours for the 4 days that follows your PRK while the surface epithelium heals in underneath the bandaged contact lens. In addition to that, we will give you a prescription for a drug called Nevanac, which is like Motrin in an eye drop form. You can fill that prescription if you do have discomfort that is not relieved by the other treatments, but I would not recommend filling it right away because you might not need it. An ice pack can also be used after the laser surgery and benefit some people who are uncomfortable. And the best way to do that is to get a moist washcloth, put it over your eyes, and put a bag of frozen vegetables or frozen fruit on the washcloth. We also will give you a prescription for a narcotic pill. Like the Nevanac eye drop, we will ask you not to fill it right away since you probably will not need it. It is offered to you in case these other treatments are not enough to produce comfort. You will need a driver on the day of surgery because the Valium we will give you will produce some sedation. You will also need a driver for your follow-up appointment the next day at our office in Washington, since we cannot confirm that you have good vision that's good enough to drive until we examine you on the first post-operative day. I think that you will find PRK to be a wonderful operation I really believe in it. I think it's an excellent procedure and is the best way to go if you are interested in reducing your dependence on glasses and contact lenses. If you have any additional questions, write them down and make sure to ask them to me, because I don't want you to have any unanswered questions. Thank you very much for your attention.